So it varies from people to people, and we might have come across a lot of pains, including acute pain, chronic pain, neuropathic pain in our daily lives. So let's have a glance at pain and its impact, especially on people who are suffering from any kind of life-limiting illness. So for that, we have Dr. Radha here. So after following graduation, she has entered Tamil Nadu service as medical officer in rural service in January 1991 and continued until joining post-graduation in anesthetics. On completion, joined Roypet Government Hospital as tutor in anesthetics. As anesthetic tutor, covered different aspects of the same, intensive care, and also was involved in the teaching of postgraduate diploma students of Kilpauk Medical College. Since 2000, uh, she have had international aesthetics experience by working in Saudi Arabia for a year and then working in United Kingdom till January 2019. She was teaching anesthesia trainees and also medical students during clinical sessions. She is also a part of the team of pain and palliative care services of Cancer Institute, Adayar, from March 2018 to March 2020. So it's my immense pleasure to welcome you to this session, ma'am. Welcome.
A big thank you to Palam India, and then warm welcome to all. In this, as in the introduction we have heard, we are going to see and learn together what is pain, and mainly we are going to look into the non-pharmacological aspects also. We'll see what is pain, what are the types of it and everything in the next few minutes, and we will have some discussion also, so that collectively we move forward in the right direction, providing the best care to the patients whom we see. So is it okay to start my presentation?
Sure, ma'am. You can start your presentation.
Okay, then just give me a minute. I will get set and get going.
Okay.
Can you all see my screen?
Yes, ma'am. It's clear.
Okay. So as we have said, we are going to see pain and its impact, and also the non-pharmacological perspective. That's the main aim for our session today. First, what is pain? See, we have the International Association of Society for Pain, which had given a definition and which was in place from 1979. But in 2020, July 2020, they have revised the definition, mainly because to help with the knowledge of pain, assessment of pain, and treatment of pain also. So they have modified the definition slightly under the care of a big elite team, which has gone through every detail aspect. And the next thing what they've considered is they've added on some salient features, 6 important key factors, which we will see. So we will see verbatim what the definition is. What exactly is the definition? It is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, and is expanded upon by the addition of 6 keynotes and the etymology of the word pain. So exactly in this, what we need to know, we have to give importance to each word. It is an unpleasant sensory and emotional experience, and it is associated with actual or potential tissue damage. See, this is very, very important. Not necessarily every time there has to be a nerve injury, okay? So every word in this definition is important, so we have to have that in mind. Next, we will go on to the 6 important key factors which they have mentioned. Of that, first one, pain is a personal experience which has an impact on, that is, it is an experience gained with underlying factors like biological, social, psychological, all features we have to have in mind when we are looking into how or why this pain has developed. Next, second point is we need to know the difference between pain and nociception. This has to be clearly understood. We will see through our presentation itself what is each definition and what is the difference. Third one, each patient's expression of pain is to be respected. Here, why is it said so? Because it's a subjective phenomenon. A cannot say, oh, B is telling some pain, oh, your pain is not important, or your pain is big, small. This judgment cannot be made. So each person or patient's expression of pain has to be respected. Next, life experiences do have a role. At the time of pain, what is that happening to them, or what was the situation? So that has an impact. We will see through our sessions why and how this has a role. Next, usually pain is said to be a symptom. So if there is pain, there is something bad underlying or something like that. But that can become a problem too. So that also we will see how and why. Last but not the least, verbal expression is not the only mode of expression of pain. What are they trying to say here? Verbal expression is one of the mode. So there may be other modes also. So we have to know that also. So sometimes it could be verbally expressed. Sometimes even if it is not verbally expressed, we can pick up. Common example I normally say is, see, intensive care patients. We do have patients being ventilated, monitored, everything. They are not going to talk to you, but still we can find out how and why. Like we all of us know vital signs. The vital signs are interrelated to the intensity of pain and things. See, for that, heart rate, blood pressure, they also have direct impact. And above all, sometimes even tears. So they may express in other ways also, even though they cannot speak or verbally express. That is what is trying to be. So these 6 points have to be understood very well. See, in the management of pain itself, understanding or explaining pain has a very big role to play. So that is why each and every point has to be remembered well. And these 6 factors, if you understand this with this background, then you go ahead and identify what it is, how much it is, and how are we going to treat it. Okay, next. What are the clinical implications from the definition itself? Biopsychosocial model. So that is what it is, just not injury, everything related to that. So this biopsychosocial, as I mentioned, that was the first point. So that has to be understood as opposed to just a biomedical or biomechanical model. Next, clearly defines pain as a learned experience. Next, clinicians should be able to deliver multiple behavioral strategies that promote activity and self-management to shape this learned experience in such a way that it helps individual to better manage pain. See, ultimate goal or aim, as all of us know very clearly, who our main patient's best interest. We are going to do everything for what in patient's best interest, so that the patient is our main goal. We have to satisfy and make them comfortable. That is the main point, and that's what they have mentioned here too. See, this is a small schematic representation. Everyone knows what it is. So I have given just an idea for you to know what and how pain happens. So for that, we have periphery, you have the nociceptors or the sensory neurons, where, for example, that also varies from place to place. If it is in the skin, you have touch and temperature. In the bone and in the joints, you have the stretch. And in the abdomen or something, you may have distension. So the receptor may be different, but the main goal is you have a sensory input, and then at that point you may have some chemical mediators involved. Then you have the nerve fibers, A delta, B, and C fibers, which carry all that to the spinal cord. And in the spinal cord, dorsal horn is the very important place. And then you have the spinal tracts, which cross over, which don't cross over. Then they all go take information to the brain, where you have the thalamus. The brain has individual centers representing every area. And then you have the descending pathway. The descending pathway, again, is important because it just transfers information, and it also has an important role inhibiting pain. So, and then everything comes back to the site of injury. So this is a concise diagrammatic representation of what is a normal pain pathway. Next, pathophysiology. Why is it so important that we need to know so much about pain? The mechanism by which a damaging stimulus in the body is perceived as a painful one by the brain is a complex one. Why? The complexity of the process results because the nervous system is not being a hardwired system, but exhibiting plasticity. What is plasticity? That it enables it to modify its function under different conditions. So the main thing, what is hardwired and what is not hardwired? Hardwired means you have only a fixed route from A to B, only one point or one mode of transmission, everything. Whereas it is not so in the brain. See, our human brain is so advanced. So that is one of the reasons. It doesn't have a strict, you can't say this is the only way it will respond. Because it is flexible to respond in different ways. There are the plus and minuses to it. Because of that plasticity is why we have a complex representation. So that also I will explain a little bit more in detail in the next slide. So that is important. Because it is not hardwired only, we are having various presentations. And because it has, once we know that we could have various responses, then we can go ahead and manage that in multiple ways. Next, pain serves a purpose to prevent tissue damage and protect the body. But under certain conditions, that pain can become maladaptive and persist for longer time. That is when you have the entity of chronic pain. When pain serves no protective function, but becomes a pathology, it itself is a disease on its own. That is why we have the entity of chronic pain and pain lasting for many period of time and pain getting transformed. All that is because of these mechanisms. Next important thing, what is nociception and what is pain? Nociception refers to the just detection of noxious stimuli. As we saw in the picture, just the stimuli, like for example, fire or cut or any type of stimulus, that detection by the receptors, followed by transduction and transmission to the sensory nervous information from the periphery to the brain. That is nociception. But what is pain? Pain refers to the product of higher brain center processing. It entails the actual unpleasant emotional and sensory experience generated from the nervous signal. So this is a gross important factors or the definition information which needs to be understood. See, few things to be taken from today's session is this is very, very essential to be understood. Next, we saw it is not hardwired. So that little bit more explanation. That not being hardwired is called neuroplasticity. Capacity of neurons and neural networks in the brain to change their connections and behavior in response to new information, which could be sensory stimulus, developmental damage, or dysfunction. So because it can respond in different ways, that is the ability of the nervous system. So that is why the various elements or different types of pain happens. See, the entirety of physiology, pathophysiology of chronic pain can be dealt with and explained for a couple of hours. But to make things concise, but at the same time not to miss anything, I'm just going to give you a very like a bird's eye view type of information. In the pain, as we saw this neuromodulation, many mechanisms are there. I'm going to give you the salient features alone. We have peripheral mechanisms and central mechanisms. Under peripheral mechanism, that is where the injury happens or at the site of stimulus, certain things can happen and make how or explain how this neuroplasticity happens. For that, we have something called a spontaneous discharge. See, at the site of injury, one stimulus could be there. There could be another additional discharge. That is spontaneous discharge. Another type of thing is ectopic firing. What happens? There could be an abnormal response in an abnormal site or an abnormal manner. So that is why. So we think, oh, there was one injury, one pain, short intensity. Why does it change or modify? Because of these mechanisms. So another thing is collateral sprouting means from one root, there could be simultaneously adjacent structures can also get triggered. So these are the peripheral mechanisms. As I said, at the site of injury, chemical mediators are released. That itself is called as an inflammatory soup. That inflammatory soup can trigger responses at the site and surrounding sites also. And it can also involve the, if it is a sensory stimulus, it can involve the sympathetic surrounding. See, in our body, we have all sensory fibers, parasympathetic, everything close by. They are not miles apart. So when there is one sensory stimulus, sympathetic, adjacent sympathetic can also get triggered. So these are the peripheral mechanisms. Next, coming to the central mechanism. In the central nervous system itself, in the dorsal horn and in certain places, some changes can happen. What are they? They are called as wind up or central sensitization. Both of them, the mechanism is the same. What happens is amplification. What is verbatim meaning of amplification? It enhances or makes something small into big. So that same amplification is what happens in wind up. When they say it is wind up is the cause, that is a short lasting phenomenon. If it is a central sensitization, the same amplification happens, but it lasts longer, maybe months, years, or anything like. So these are the basic mechanisms, how and why it happens. Next, what is the significance of all this? So pain is a multidimensional and complex phenomenon that requires comprehensive ongoing assessment and effective management. So from all this, hence good knowledge is very, very essential. So with the background what we have got, we will just move on to the other factors which we need to cover. Next comes, what are the types of pain? Generally, one more point I would like to say, generally, whenever you look or consider pain as a symptom, you would always ask site of pain, nature of pain, duration of pain, whether there are any specific aggravating factors, relieving factors, and next, not last but not the least, whether this pain is affecting your daily routine, whether it is affecting your sleep. So all these are, whenever we get history, we will get all those things. Then our point is to find out what type of pain it is. So in that, what are the different types of pain we're going to see? First, it could be an acute pain, just present at the site of injury, mediated by nociceptors. Next, chronic pain, which is related to pain in conditions such as diabetes mellitus, arthritis, tumor growths, or any long-drawn diseases. Next one is somatic pain, which is generated by nociceptors in deep tissues. Next one, visceral pain. That pain which arises from deep viscera like gastrointestinal pain, any abdominal distension pain, etc. Next is neuropathic pain. Neuropathic pain is caused by damage to nerves, resulting in increased firing. All those peripheral factors which we saw, and then that is one of the causes for neuropathic pain. Next, the next to what we're going to see are more of neuropathic type of seen in neuropathic pain. Allodynia. What is allodynia? Allodynia means pain resulting from a harmless stimulus. See, this has to be clearly understood. Normally, this stimulus should not cause pain. Common example what is given is pain to touch. When there are people having neuropathic pain, this is a common complaint they will say. Their own touch to that area, for example, they have pain in the knee. Their hand touching the knee or even clothes touching the site could trigger pain. Normally that shouldn't, because see, otherwise common example, handshake we all do. If touch is going to cause pain, none of us will do. But in these situations, when there is a neuropathic pain, touch can cause pain. So that is one of the common symptoms. They themselves say, I did not know that before, but just now, even touch of my own hand or my clothes does trigger the pain. Next is hyperalgesia. What is this? This is an exaggerated response to a normal stimulus. For example, one particular type of pain stimulus, for example, the pain should be like to a score of 2, but that can cause a pain to a score of 8 or 10. So that is hyperalgesia. Last one, referred pain. Pain felt in an area other than the site of origin. for this common examples, which all of us know is myocardial infarction pain. See, it should be in the chest, but sometimes we very well know that the pain could be in the left inner aspect of the arm, or it could be in the chin, throat. So these are all, this is a common example. And next, recently, we all do a lot of laparoscopic surgery. So whenever when a patient has had laparoscopic surgery because of the inflation, after surgery, they may have pain in the shoulder. Why that happens? Because of air under the diaphragm. So there's the site is somewhere, but the pain is somewhere. So it's the same nerve supply. That is what we need. So that is why I see knowledge of what it is will help you to diagnose and treat. So you'll say, oh, this is why it's happening. So most of you all work and plenty of lab procedures being done, you will be telling, oh, don't worry, sometimes you may have pain and that will go away in a couple of weeks. Once the air gets absorbed, whatever the gas gets absorbed, then the pain diminishes and it's completely gone. So for us to know what it is, so referred pain, that is a common example. Next comes, how are we going to assess pain? What are the pain indicators and how are we going to do the assessment? Main, again, assessment of pain is also important for study purposes also. So both for research and study and for treating patients, we are going to use the assessment. In that also, we have clear demarcations for acute pain and chronic pain. From acute pain point of view, we have the standard numerical rating scale, visual analog scale, dynamic pain assessment. Why dynamic is important? Sometimes they may say, oh, I don't have any pain when I'm at rest. Only when I start to move, I have pain. So, and you also need to know the baseline pain assessment. What is there? Again, as we saw in all these things, first assessment, then reassessment regularly is very, very important. And again, I am going to show some slides of what are the various assessment tools available. But again, everything tailor-made to the local area is the best, okay? Because you have to see what suits your patient, their demographics, their educational status, what is that? Because we need to get the maximum information from them to provide the best benefit for them, okay? So next, from chronic pain point of view, we have the multidimensional qualitative tools because we have multiple factors. We have to consider the several disease and patient-specific scales are available. As we saw, the chronic pain could be due to tumor, arthritis. So we have to go into those factors also. And then we have specific neuropathic pain assessment charts and tools available also. So the normal thing which is used generally is the numerical rating scale, because we tell patients that, for example, if 0 is no pain, 10 is maximum pain, grade and tell that. Nowadays, most of them are able to say, and no, or sometimes no, I can say whether it is moderate, mild. Okay, if they explain like that, take that and correlate to the scale or visual analog scale. Whether if 0 is nothing and then maximum, whatever you put that as max. And then you have the pictorial representation also of this. So with this, now, even if someone can't put numbers on it, you can say if this is how they feel. So because we will see patients of different caliber and things, and nothing wrong. It will be better that we are well prepared to manage and deal with everything. And this is something which will be very, very useful. Just a picture of front and back. So you give this to the patient, you can tell them to mark where they have the pain. And then you add on other factors, as I said, whether what type and nature. And then so that this will give them some help and confidence also. So they are able to express where their pain is, and that will help us also. And then if you have any of these charts, you have one as a baseline. And then, as I said, for assessment, diagnosis, it's going to help. Next, you start some treatment. And then you go back to it again. Regular review, either by the main physician or by the nursing team or whoever it is. So regular reassessment will help us to give the best treatment for them. For example, you start on something and you see in 2 weeks time, either you see or your team see, and then get an idea whether has that had any impact, positive, negative. So accordingly, if it has had a positive impact, okay, I can continue on that. Or if it has not had, so maybe I'll have to change my mode of management. So regular first baseline assessment and then regular reassessment will help you to give the best care. Next, from what we're going to see the other elements also. What are the important non-pharmacological aspects and how are we going to manage that also? What are the factors affecting pain? The pain perception. Perception is how it is felt. Then cognition, how it is understood, how it is perceived, and how it is represented. So this is very important because each one of us have different thoughts, different ideas, different correlation. So everything is essentially important. Next, beliefs. Then the next one is socio-cultural variables. That has a very big role to play. And then learning. And then last, emotional reactivity to that each response of the pain event and everything has a role. So all these factors, every individual has a role, how the pain is going to be depicted or how the patient is going to perceive it. Now we'll see what are the psychological aspects of pain. It's a social or communicative function. It's interruption of mental preoccupations. Once the pain is there, they're not even focusing on anything. And it triggers other behaviors. Yes, personality changes, many things can happen. Each individual's experience of pain and its expression is a product of the sensory experience, the person's personal background, the interpersonal context, and the meaning it has for that individual. So that is why we saw in the beginning itself, it's a sensory, unpleasant, emotional experience. So all that they have given, they will have the impact. So basically, we are going to see what are the psychological components and how are we going to manage it. What are the things that can happen? It can result in anger. It can result in sadness or an anxiety state. It can increase the stress levels, and ultimately it can cause muscle tension also. So how can these be managed? They can be managed generally to a great extent by breathing exercises. Normally, such breathing, slow, calm breathing, then inhaling, exhaling for specific period and specific type of inhalation, exhalation with breath holding, and then the pacing, we say. Pacing and breathing are very, very important tools which are being taught. And then meditation is one such technique. Relaxation techniques are taught. With that, to a great extent, stress and anxiety is not only dealt with, muscle tension also will be brought down. So we'll now go into the non-pharmacological pain management. This method utilizes ways to alter thoughts and focus concentration to better manage and reduce pain. We will see in detail what it is. What are the non-pharmacological methods? First, education and psychological conditioning. So far we saw, first, it is very, very essential to explain to them that this education and psychological conditioning is called as explaining pain. What is pain? How? It is one of the important sessions because not everyone will be aware of all these things. So first and foremost, that is why it's becoming to a very great extent, pain is included in the curriculum in many aspects, because long before it was not part and parcel of training. So this has to be understood mainly. That's why it's called as explaining pain. What is it? So it is just not injury. It has got so much of this changes which can happen in the nervous system, brain perception, your belief and your thoughts do have a role. So everything, understanding pain or explaining pain is first important. So that has to be done. That's the education and awareness teaching. That is what it will comprise. Next comes hypnosis. Hypnosis is used to a very great extent to treat. How? They have various techniques are used. It is called as either an imagery technique. They give you some ideas and thoughts and suggestions to have, see, always some thought is triggering some bad or negative. So that is replaced by positive or good thought. And then you have distraction techniques. You're always worried and confused. So what can you do to divert from that state to another? And then you have, as I said, the relaxation. That also, those are the three common techniques used under hypnosis. Next, we have comfort therapy, where we have heat, hot or cold application. You have music relaxation, general exercises to relax oneself, those type of things. Next comes physical and occupational therapy. In physical and occupational therapy, you actually give them physical exercises, something which could be done and managed in such a way so that to help with their muscle training. Next, you have psychotherapy. In psychotherapy, you have either counseling sessions, you have individual counseling, family counseling, or group counseling. See, in many such type of chronic situations, even individual, it all depends on the condition of the patient. So initial stages, individual counseling might help. Then group counseling also will help. Why? Because many times they think it's them, the only person who is struggling. I am in so much of pain. You don't know how much I'm going through. Yes, we do understand. But when they meet others and they meet them as a group, so group counseling in chronic pain sessions is very, very helpful, because they will come to know, oh, it's not only me struggling. 10 people meet, all 10 will have the same thing, but they wouldn't have revealed to somebody else. So that might help. So group counseling also helps. See, all these not only for general, see, all what I'm telling for general is applicable for palliative care also. And the main thing to understand is we will just tailor make it. The concepts are going to be the same. So what would that be different? So in, for example, in very sick patients, we have to give them some individual counseling and explaining to them what exactly is the disease, what is that they can do, what is that they cannot do. For example, I would say for any type of palliative care patient, their weakness and tiredness is very important. We have to explain why is it so. That's mainly because of the disease and because of their frailty. They are unable to eat. So give them some techniques like, see, large quantity meals they may not be able to take, small frequent meals. So these type of things. So energy is looked into there. So, and then exercise point of view, we have something called as chair exercises for people who are so ill and can't do anything. Sit, stand in a chair. So there are, for everything, there are options available. So we just have to know what it is, and then accordingly help the patients and the carers also. So for example, in palliative care mainly, the patient and the carer, we have to give equal importance, involve them both, teach them both what can be taught. So these few examples I'm trying to say as we go through, because for you to relate stuff. Next is neurostimulation, in which you will have acupuncture, acupressure, TENS machine, all that. See, this TENS and those type of things, the main mechanism, what I said in that diagrammatic one, the descending inhibition, that is how there is a separate pathway. Like, for example, when someone falls or something, we just rub that area and then that relieves pain. How that happens, that there is a very important pathway in the descending pathway, whereby touching or rubbing, what we do, the A beta fibers are stimulated. What they do when they are stimulated, they cause the negative impact. They cut the transmission of pain. So that is important, something called as gate control theory, which is very, very important thing. In 1965, that was found out. And that is a groundbreaking type of thing to help it. That is the basis how TENS machine works, and that is how whenever there's a fall, they rub. That is the main basis how the pain relief happens. Next, so now what we're going to do is we'll see some salient in pictures so that you are all able to understand some things. CBT, or cognitive behavioral therapy, is one of the common technique used. Why? In this, if you see in this picture, you have thoughts, feelings, and behavior. All these three are interrelated. How and why? So whenever for example, some feeling. I'm just going to take a simple example, back pain. See, because back pain is something many 6 to 8 out of 10 people are set to go through with it. So once you have the symptom of back pain, immediately thought might come, oh, I'm not going to be able to do anything. That is it. I can't, my future won't be okay. So all these unnecessary thoughts, because see, everyone has back pain, and with some form of exercise or anything, it will become all right, and it will be lasting for some time. And then you will be okay, because that is how all of us see. But those episodes and events trigger multiple factors. So this is a vicious circle, we say. And what is done in this by these cognitive behavioral therapy techniques are, you try to break the chain. This interrelated thought, feeling, behavior chain is cut, so that you don't go on and on with this, and then you're able to come out of it and still able to perform. So next slide, next few slides, I'll tell what and how to manage this also. So this is a common technique used. As I said, what is the technique that you can use? This is a very simple one. It's called as a SMART. What first, each one we will see. SMART, yes, denote specific. You be clear what you want to do, rather than beating around the bush and confusing yourself. So what is that you'll be able to do? And use simple words, simple techniques. Even for example, you want to give a plan, say simple thing that better always to give the choice to the patient itself, so that ask them to say, and then if pick something which helps them. So be clear and specific. Then measurable, provide a way so that you can identify, so they themselves know, oh, I was able to do this, so that is good. So from nothing to something possible. Next, achievable. Don't go for something which is not at all possible. For example, I'll say a 75-year-old cannot go and jump or run or do something. So give something which is achievable by that particular person. As I said, palliative care patient who is so frail, for them a simple chair exercise, or just sit, stand, holding on to something, or bending like a stress ball. So something which they can do, not which something they will not be able to do. So that is where achievable comes. And then relevant, makes sense. So something which is connected to them, and that will be, so they will also relate it to it, and they'll be willing to do it. And then time bound, don't have a very, very long time frame. You give something, for example, ask them to do this 5 minutes 3 times a day, or 10 times morning, evening, something like that you give for 1 week, and then see the impact. They by doing all this, they will be able to measure and see the benefit for themselves. So that is what will make them to be committed to what they're doing. Because in all these things, no point A telling it to B. B has to take it, try it, and be committed to that to get a response or a positive feedback or a betterment. So everything is important, and do it in such a way so that the patient is able to understand, do it, experience it. And as I said, they have to be committed to it, and then they have to have a regular pattern, stick to something what has been advised, so that they get the benefit. And once they identify the benefit, then we are not needed. They themselves will pursue doing it. So the same thing what I mentioned before is called as a perseverance loop. As we saw, the pain perception leading to threat activation, because they are scared, they are worried that they won't be able to do, the threat activation happens, and then that is why the problem comes. So they stop doing anything. So by stopping to do anything, the physical activity is stopped. So muscle loss, muscle fatigue, everything. So we should try as much as possible to break that vicious circle. So if the problem is solved, no problem, it will be good. If someone picks up what we explained, for example, if that is not solved, what happens? The threat activation goes on again and again. The perseverance loop it gets triggered, and then this goes continuously into a vicious circle, not causing any betterment to the person. So how interventions to break the perseverance loop? So our main aim should be to break the perseverance loop. So by using psychotherapy involving physiological changes, by using cognitive therapy, cognitive behavioral therapy, and by addressing the hypervigilance and threat phenomenon, and also you can use the emotional therapy. So this is another representation of the same thing. So chronic pain, decreased activity or deconditioning happens. As I said, if it is not controlled there, so then negative emotions, avoidance of withdrawal, they totally stop doing everything. So that will lead on to distress and disability. So ideally, between 1 and 2, between chronic pain and decreased activity is what we have to enter and use either any, see, all so many things I have said, not necessary you have to use A to Z of everything which has been said. That is where you have to use your individual technique. Identify and diagnose what's the issue. Mainly personality. You, by talking to the patient in few minutes, you'll know what type of personality or what is the issue. So deal with that issue. And then, so once it is dealt with it, you will not be going through the entire circle. So if decreased activity and deconditioning itself, you're checking before that, you're giving some simple techniques. Don't worry, you can't do this. You do, for example, you can't do 30 minutes. You do it for 5 minutes. Break it into 5 minutes. That will also give you the same 30 minutes. So by breaking it into 5 minutes, they are able to do it, give a break. And because they're able to achieve it, they will develop their own self-confidence. So those are the things which, so this is how you have to tailor make everything to the individual. And always, if it is a multimodal or multimodal management, you have multidisciplinary team involved. So that helps each another. The physician, the physiotherapist, psychologist, counseling, social work, all together, you could provide the best to the patient. So we'll see what are the benefits of non-pharmacological methods. What does it do? It reduces feeling of anxiety, reduces feeling of weakness, and it decreases the pain behavior and pain levels. Very important. It can also decrease the use of analgesics. And ultimately, it will enhance functionality and activity levels, increase the individual's ability to control feelings. And one more thing, diet also has an essential role. Why? Rich protein diet helps by strengthening muscles during physical training therapy. So that is very essential and has to be borne in mind. So the main thing, what I would like to say is the important factors are physical and psychological treatments have to be considered. They have to be encouraged to be active as much as they can. At the same time, don't push them too hard. Tell the patient, don't push yourself too hard, because why? If they push themselves too hard, that day they may do too much, and then for 4 days they won't do anything. So in this point, I would say always we teach them something called as pacing. No peaks and troughs. So if they have like see, all of us are, whether you like it or not, having one systematic, like you have a timetable. If you have like that and keep to that and keeping to that in their activity, so that they don't overdo, because if they do little every day, they will not go into unconditioning or not doing anything, because especially with muscle, if you don't do anything at all, it goes into something called as disuse atrophy. We don't want that to happen. So whereas if they overshoot and do something, they may go into too much pain, and then that might cause a unwanted, this we saw thought, feeling, belief and behavior, everything. So we don't want to push them to that state at all. So that is why this point, don't push yourself too hard, is very, very important. So they have a sustained, steady state. And then last but not the least, stay social. That is important, because you just go outside and see something that can change the person's mood. And by meeting and seeing others, it can help each other. Generally, one more thing before we finish, I would like to say, Normally, I say, if, for example, any treatment of thing, if you take it as 100%, you could split it into 25%. So first 25% would be educating or making them understand what the problem is. Second 25% is physical exercise, activity, and pattern. Third 25%, I would say, calming, relaxation, and diet also comes into that. Last 25% will be the medications to help them. So in this, every 25% has equal importance. So you do 125 very well and leave the rest, or giving importance to one and not the other will not help in the long run. So overall, it should be a combined multimodal, multidisciplinary approach to manage this is what would give them the best benefit. Thank you, one and all.
Thank you, ma'am. Thanks a lot for that very detailed session. So for me, I'm attending your session for the first time. So before that, senior used to tell me a lot that you are such a humble personality and your sessions are just awesome. So I could witness that.
Shall I stop sharing my screen, dear?
Yes, ma'am. You can stop sharing.
And that's 1 minute.
So thank you, ma'am. Once again, thanks a lot. So we have a question in the chat box by Mr. Joshi Jonas. Is craniosacral therapy can be considered as non-pharmacological method of treating pain?
See, that's why this non-pharmacological aspect is a very, very vast one. First thing, big thank you. See, it's always an interactive session, isn't it? Like, no point anyone having the knowledge. It has to be shared. And ultimately, I want everyone to have the benefit, learn and give the best benefit to the patient. That's the aim and goal. That's why we have all come to this profession. Okay. So first, thank you for that. And coming to the question, see, multiple craniosacral therapy can be, yes, it is one of the methods. See, for that matter, anything other than medication is all non-pharmacological. So, but again, like you may have some, what is the exact query is do they want to know craniosacral therapy can be considered as non-pharmacological method of treating pain? See, what is the technique that they do there? By that craniosacral therapy, what is he mentioning? If he could say, and then accordingly, I would answer that. Because there are multiple methods. You can just do an acupressure to the sacroiliac, because in the craniosacral therapy, and you have many, it's basically the nerves that you're involved. That is where you're dealing with. So any particular query they want to mention, if they type on the chat, then I will answer to that.
Can I speak about it, madam?
Yes. Go ahead.
I've just come across this particular thing on my YouTube, that touch therapy or craniosacral therapy, which is a non-invasive method. That is number one. Number two, it is just a gentle touch, basically at the cranium, and this gentle touch relieves a lot of pressure where the where the what we call the cranial fissures are opened, and there is a what we call better facilitation of pain perception, and the pain is reduced.
See, exactly as I mentioned, no, this is what is first what I mentioned. No, whenever someone falls, you rub. Somebody falls, or even when a child falls, you rub, and then the pain goes off. Exactly. The by the end, before I'll show you another slide, maybe 1 minute for your answer. I will share my screen once again here. There's a pictorial representation which might help them. Can you all see now?
Yes, ma'am, it's clear.
So that's all. See, this is what I was trying to say as gate control theory of pain. Exactly, any touch. If you see the picture on the left side, you will see A beta fiber on top and C fiber below, and you have the inhibitory neuron. In the first picture, only the C fiber is triggered or C fiber is open. You see the other two as blocked. So in the first one, there is no touch. So when there is no touch, only the pain is transmitted. Whereas if you go on to the picture on the right side, you have the A beta fiber, which is what is that touch, rubbing, all that happens through A beta fiber. So when that is stimulated, you see what happens. A beta, see, the pain fiber is still is there. The pain stimulus is there. But because of A beta is involved, finally, if you see the picture on the left, the pain perception is what is there. Whereas in this, the pain perception is blocked. So this is the main basis which I was trying to say. This is what is called as gate control theory. This was identified in 1965 by Melzack. Anywhere you see, this is the basis or the main groundbreaking thing for pain relief through all these techniques. This is what I explained by words. Good that he brought it up, and it's that you've had a chance to see. So this understand. See, again, understanding this. By this, the picture on the right side, you see all the stimulus is there, but pain alone is not there. This is the basis. Okay. Hope it's clear to your idea.
Thank you, madam. It's quite clear, and it's also I look forward to using it as a beneficial.
Yes.
Tool.
It can be tried.
Yeah.
It can be. See, especially in palliative care, we have to see what best we can do with very minimal intervention. So you have, that's why TENS machine in different forms, multiple electrodes, different types are there, peripheral nerve stimulators are there. So anything like that, that's why acupuncture, acupressure, all that can be tried. So basis is mostly for all of them is this. But acupuncture and acupressure techniques will involve individual areas, individual brain representation, everything. That's again interconnected through the nerves and the representation in the brain. In the whole cerebrum, individual representation is taken into consideration, and then peripheral mapping is done, connecting both. So this any therapy which involves, that's why you have massage, all that helps in the same way. And then next thing with massage, all those things is that it relaxes the muscle also. Muscle tension is also relieved. So it's worth trying, especially when patients are so immobile, nothing could be obtained. And many situations you may be seeing patients who are unable to swallow. So you may have the medicine, but if they can't swallow, what is the point? And so then next is you have patches. If you don't have, say, we have to always see what is available. This WHO itself have said that even though opioids are available, getting or providing the opioid to the patient at the point of care is where the whole world is finding the difficulty. Yeah. So that is why even in the 80s and 90s, they've released so much of information that opioids is now available everywhere. But making sure that the opioid is available to the patient is a problem now. So like that, in that case, any other method of management, if we can do, see, dignity of patient, best support at that time when they need it, even little things you do, the benefit from the patient and the satisfaction that they get is what we are looking for. Very good, worth trying.
Thank you, ma'am. So we have another comment in the chat box by Dr. Chandrasekhar.
As I know.
As I know, craniosacral therapy
for
is
depression and psychosis to stimulate serotonin. Yes, see, that's all. Again, from that point of view, we have all these endorphins. just simple exercise. Why are we all screaming about walking and exercise? Because there is evidence that endorphin release is increased. Endorphin release makes you feel better. So it's all interrelated. By causing that, and if the endorphin release is there, so then that is going to help them. So 50%, one is physical activity, and then feeling better, and then automatically they won't go into the loop or cycle of going down. They themselves will elevate themselves. So it's worth. So there are multiple techniques, and I say no. Next thing is mindfulness is something very much used. Staying in the present, and so those again that also is taught through breathing techniques, and many cultural and spiritual impact also has to be borne in mind. For that also, there is enough evidence-based information available, because we have done some quality of life questionnaire assessment, where they have found that this people who have, you said you were talking about spiritual and religious beliefs. There again, like nociception and pain understanding, you have to know what is the meaning of religion, what is the meaning of spirituality. So religion is just some belief and customs done, whereas spirituality is something beyond. Meaning of life, purpose of life. What is that I'm going to do? What is that I can get? What is that I can do to everyone? So people who have those beliefs, they have found their quality of life, and even in palliative care, they deal with things better off. So that is why it should be an overall, in total care, not one part. We have to cover everything. That is what gives the best. Anything else in the chat?
I have one more inquiry. The myofascia release, which is said to be the very gentle technique of addressing the fascia which gets knotted or dehydrated.
Correct.
And how would this be also part of the program that we can pick up with the patients?
No, see, for that, no, you have focal points. So it could be same like knotting or whatever they say. In the whole body, they may have specific areas. So that particular area, it may be, they are called as focal points. There are some 40 to 50 points in the whole body. In between shoulder blades, for example, I'm telling. So that's a common thing. That is many myofascial disturbances. So again, in that we use both. You can use non-pharmacological technique, and pharmacologically also we have something called as, we inject trigger points. Even pharmacological techniques are used, and trigger point injections are given. So that is the pharmacological one I'm saying. Non-pharmacologically, it is exactly the same. You do pressure and pressure application and relief on those particular points. So you can combine all these things together. So again, you should know, for that, one of the common things is you can have a pictorial, like as I showed you, that anterior posterior body, you know? So you can identify the points, which are the pressure points. Like we have pressure points for sore, like in our whole body, you have these specific points in the body where they complain of pain. So that is where they say there's knotting and things. So that you identify them and deal with them separately. Again, all touch and pressure only is used there. Whereas, as I said, in pharmacological point, if you ask, there's something called as trigger point injection. We give local anesthetic, and then we even add sometimes steroids to that. See, it all matters. It depends on how much. For example, some people get very good relief for a few months. So by one injection, if they get, so it all depends on individual. Whereas some say, no, I get only for 10, 15 days, then we don't repeat. If the effect lasts, similar only, acupuncture, acupressure and all, there are people, for example, for headaches, acupuncture and acupressure have said to give, because we have multiple headache. You have tension headache, migraine headaches, there is a whole load. You can have big list of causes for headaches. So in that, acupuncture is said to have a very good effect. And there are people for whom it gives relief for 3 to 6 months. And they are free of medications in that period of time. So similarly, they are all pressure techniques.
Ma'am, Mr. Sami has raised his hand. So, sir, do you have anything to add?
Yeah, I had a small question. So, ma'am said the pain charts are very useful, and you said like it has to be done on a continuous interval. So I just wanted to know like what the ideal interval for like doing those, like between baseline intervention and yeah.
See, again, it all depends on our resource availability. Okay. 2 weeks, 4 weeks is what, again, nowadays we have very many different ways of dealing with it. Ideally 2 weeks, because you start them on some medication, and then 2 weeks time, okay, you cannot go and see them personally, do a telephone call. There are very many options available, because 2 or 4 weeks, it depends on what you're starting. Okay.
Yeah.
And either you go see, or if you cannot go and see, you send your team, or next option is to do a phone call. And ideally 2 to 4 weeks. If in 4 weeks time, they should have some benefit. And then anything you start, you have to continue for 2 months. Before 2 months, don't say it is not working. Okay. So that is something we have to have in mind, because everything, because all these medication or non-pharmacological or non-pharmacological, whatever it is, you stick to this. You start, do something 2 weeks. If you can reassess in 2 weeks, well and good. Or you reassess in 4 weeks. And then at that point of reassessment, as I said, you have to be very clear whether it is having any impact. Even 50% relief, okay, you continue with it, and tailor-make, you add something more or reduce, you can increase the frequency, something like that you do, and reassess. And when you second time reassessment, there should be a reduction in their pain score. If there is no reduction, then totally fine. Go back, start from square one. Okay. That is what will be ideal. And then every time you can't see, that's why you have a team. Either you yourself see, and in that place, these charts will come handy, because everyone is using the same thing. ACs or BCs is using the same thing, no? So they make it universal and helpful for everyone. So 2 or 4 weeks would be ideal, and ideally 2 months you have to follow something to get the benefit, because many times what happens, they may not be following it regularly, or something happened. Simply, I'm giving you in life examples only. What patients say only. Sometimes they'll say they would have had for 3 weeks. No, I went somewhere. I did not take my medication or whatever. I did not do that at all for that 1 week. Then how on earth the benefit is going to be there? So it's like break. So we have to ask in detail. Were you following the same thing? For example, if you have told them to do something, were you able to do it, or how many times it? So next thing is maintaining a diary. You give some instruction, tell them you pain diary and response, pain diary it is called. It is very, very useful. You tell them to note down in this week, how many episodes. I've started this management, and with this, my episodes before was five times in 4 days. Now it is only 2 times in 4 days. So they themselves, if they write it down and bring it to you, to evidence, you know how they have had, and they themselves have an evidence. What does the treatment provide? So assessment and the diary will help in a very good manner, both for them and for us. So, and all this documentation, if you can have, that is the data. That is evidence-based finally.
Yeah. Thank you so much.
Welcome.
Thank
And
you,
one
ma'am.
question was in the chat box. 1 minute, dear. How is sleep disturbance connected to muscle tension? See, again, sleep is a big story. Sleep, you can, muscle tension, you have REM sleep and REM sleep. I have to again go back to that. So sleep and complete relaxation and rejuvenation, all our energy. If we all don't sleep, the next day we won't be working very well. That's why we all have to sleep. So that is so important, and it does have an impact on muscle tension and things. So if someone is going to be tense, they will be more on REM sleep only. They will not be on NREM sleep. NREM, you have, like, quickly I would say, you have 90-minute, all of you know that, but quick recap. You have a 90-minute slots of NREM sleep. That is when complete recovery. See, we have something called as basal metabolic rate. So all our basal function, everything gets refilled. So you have something in for sleep itself. You have sleep. You try or teach them sleep hygiene. It is called. Like other thing, there is something called a sleep hygiene. What is that? You don't keep on, you want to have a proper sleep, you have to have a proper routine. You don't keep on doing, you're keeping your activity level at 200% just while you're hitting the bed. You will never sleep. So see, for someone who is very active, laborious, you're tired, you're going to sleep, that is different. For people who are complaining that they don't sleep, they have to strictly follow sleep hygiene. So that is something which has to be considered, and then it does have a role. There is some other question somebody wants to ask, I think. Yes, go ahead, Gautam.
Sir, you are muted from your end.
Yes, good afternoon, madam.
Go ahead.
Yes. So yeah, thank you. I need to just ask, I'm a geriatric healthcare from the, so just I need to ask one question regarding the pharmacology. If a adult person has been taking SSRN medication for conservative medicine for sleep disorder, and if doesn't work, so at this moment, psychiatric doctor recommend or suggest to a typical type like antipsychotic medicine, for example, clonazepam, olanzapine, for how long he can take if he will like a withdrawal the medication. So if the patient will back to the again the sleep disorder, or will helpful in a like a serotonin.
No, see, that depends. If let's see, for example, olanzapine and all, what you're telling may be a long drawn psychiatric issue. Those medications cannot be stopped. You have to continue. So you stop that and all, you're inviting trouble with open arms. Don't ever do that, because they might have been on those medications for umpteen years.
Yes. Okay, madam.
So that's only tapering down. What you can do is, the dose can be titrated.
And so, and second, sorry for interruption. And like for example, if the patient has a the like a diabetic stage DM2 type 2, but there is a side effect for the clonazepam for raising the the fasting blood sugar. So in this case, what he has to do?
No, those type of
this
things.
medication is helping in a sleep disorder, for example, like insomnia, but the second side effect is gonna be.
No, that's what. So these things, you have to be dealt with the specialists only, because to both psychiatric issue and the diabetic issue, you can't just ideally. It is best to be dealt by the specialist. Okay, so you don't either, because a very important question that any diabetic patient will have their issues, and then this SSRIs can have impact on those impact. At the same time, those psychiatric patients cannot be stopped on that also. So ideally, you refer to them and they will titrate the dose. Okay. For example, if the blood sugar level is very high, at the same time, you cannot stop the olanzapine or anything like that completely, because they're managing them. 1 or 2 days stopping, you won't see big difference. But because they've had it for many years, the blood level will always be there. It is not going to touch the zero level. Like next, you need to know a little bit of pharmacology, pharmacokinetics, pharmacodynamics, because those medications have a very long half-life. So, so that has to be understood clearly. So best bet, I would say, has to be dealt by the specialist, and you please don't go meddle with any of that, because they will titrate both.
Yes, this is because my elder
titrate,
brother, this is the case from my elder brother, that he has because of the sleep disorder, because of the workplace, and he has been taking, so, but it's helping as well as, but okay, madam, thank you so much. I really appreciated your response.
no
Thank you very much.
problem.
Thank you, ma'am. I think we can go for the case presentation now.
Yes, yes, yeah.
So we have Ms. Mukta Davalikar, who is a clinical psychologist by profession, who is one of our participants. So I invite Ms. Mukta for the case presentation. Hi,
Hello.
ma'am. Hello. Yeah, it's audible.
Okay, yes. All right. Yeah. So, first of all, thank you, Radha ma'am, for such a wonderful session, and thank you, Palem India, boss. Before I dive into the case presentation, I would also like to give a disclaimer that I have not had much time to prepare. So, please excuse me if there are any flaws. Going ahead, today's case is she's a 47-year-old female who was diagnosed with CA lung, and she was working as a factory worker coming from a low socioeconomic status. Yeah, so to give you a brief medical history, she was basically she was seen at a local primary healthcare center with complaints of pain. From where she was urgently referred to Goa Medical College for further assessment and treatment. There she was diagnosed as last stage CA, and the primary caregivers, that is her husband and her daughter, were informed about this. But the patient's relatives insisted that they would take the patient with them to Karnataka, which is their native place, and treat her over there. During the journey to Karnataka, also, she was reported to have been in extreme pain. She was losing consciousness in between, and she was in a lot of distress. But she was still taken to Karnataka. The doctors over there had also informed the caregivers that there was no curative treatment which was possible at that stage. There were also meds at this stage. And so the doctors in Karnataka had asked them to either take the patient to Tata Memorial Hospital in Mumbai or to go back to Goa Medical College. The relatives, when I say relatives, I mean extended family. They were very much insistent on taking the patient to Mumbai, and because they didn't want to, leave her untreated. That is what they felt. But the primary caregivers, that is the husband and daughter, decided to bring the patient back to GMC. They had certain logistical reasons also in mind. One was being that they had always stayed in Goa. So for them, there were more resources available in Goa. There were also, the place was familiar. When it came to finances, also, they wouldn't have to spend, they would have had to spend more money if they had gone to Mumbai. So those were some of their concerns, along with the fact that they had seen the patient be so distressed during the travel, and the doctors repeatedly saying that there was no curative treatment. They resisted the relatives, and they decided to bring her back to Goa. They took her to GMC, from where she was referred to the Lhasa Center for Palliative Care in Goa itself. When she was received there at admission, she was in pain, but there was no verbal response. There was also no food intake, and within 2 days, she went to a comatose state. Speaking of insight, we could not, since I saw her when she was brought to the Lhasa, I could not assess patient's insight in terms of diagnosis, prognosis, and palliative care. But when it came to the family, as in the immediate family, the husband and the daughter, were well aware of the diagnosis through the doctors. The patient's daughter is aware of and has accepted the prognosis of the patient, but the husband is still in denial. And both the family members do understand the scope and purpose of palliation. That is, they do understand that this is not a curative treatment. They also understand that we are trying to keep the patient as comfortable and pain-free as possible. Family overview, the patient comes from a Muslim family, whereas her husband is from a Hindu family. Because of which they are both estranged from their families, the extended families, for quite some time now. The extended families have only gotten back in touch after the patient was diagnosed. They have one daughter who is 20 years old and is extremely attached to both her parents. Speaking of the family history, as I already said, the patient is a Muslim married to a Hindu against the family's wishes. Since marriage, both of them have moved out of Karnataka and they've come to stay in Goa. In recent times, some of the family members have re-established contact with them. Both the patient and her husband work at a plastic factory together. They have worked together for over 20 years now. Their financial conditions are poor. They have a daughter. She is 20 years old, who was doing her graduation in English. She was in her final year at this time, but although being a bright student, she has not answered her final graduation exams, and she has decided to drop out and take a gap year after discussing the situation at home with her head of department and principal, as she is unable to manage the caregiving duties and the academics simultaneously. Because even though the extended family is insisting that they take her for treatment here and there, they are not really actively involved in the caregiving duties per se. And it's only up to her and her father to provide her mom as much care as possible. Since being brought back to Goa, the patient's husband is in denial regarding the prognosis. He has immersed himself in work, due to which the daughter has to handle all the hospital formalities, the admission, all the other procedures on her own, which is quite a stressful situation for her and quite a lot of responsibility on her shoulders, given that she is pretty young and has not had any exposure or experience in something like this. The patient's husband also tends to not visit the patient every day. He comes maybe once in 2 to 3 days. When he does come to visit, he gets angry that the patient is not responding to him or recognizing him. He also tends to shout and yell in the ward when that happens. This does cause the daughter significant distress. The daughter is close to one paternal aunt, though, with whom she does speak over phone almost every day, and she feels really close to her. So, coming to the eco map, just looking at the context in which the systemic context in which we find the patient and the patient's family, there is a positive relation when it comes to the family, I mean, the patient and her husband's boss, that is the factory owners and the supervisors over there. They have had a positive relationship, although they are not overly supportive or going out of their way to help them out. But they are understanding and they do have a positive relationship. The same goes with the daughter's college as well, with the management and the faculty over there. There is a stressful relation when it comes to the extended family. Some of them are still not in talking terms. There is a tenuous relation between the patient and the religious organizations, given that it's an interreligious marriage. Since then, they have not really followed any particular religion or any particular kind of rituals, etc. They have a very strong relation with the husband's sister, that is this daughter's paternal aunt, as I already mentioned, and with the palliative care center as well, and they see it as their primary support system. The socioeconomic overview. As I said, they come from a low socioeconomic status. Both of them do not have a permanent job currently, since because of the patient's state. The patient's husband is the sole breadwinner. They live in a two-room house, which is again provided by the company in which the couple works, and they do not have their own home. There is no financial support coming from any family member or friends. A psychological overview, psychological assessment of the patient was not possible per se because the patient was in comatose state. So here the main focus in this case was on grief work and support for the family, especially the immediate caregivers. The daughter faced significant stress. She was neglecting basic self-care like bathing, combing her hair, etc. She absolutely refused to move from the patient's bedside in the fear that something would happen to her in just that period when she was not there. Caregiver burnout was a very real concern in her case. She also reported significant anxiety regarding the future, as well as the decision that she had taken of bringing her mother to Goa against her relatives' wishes, especially because the relatives kept calling her and pestering her about it, saying that she was still young and did not know the world and she should have listened to them. Anticipatory grief was definitely present, where she knew and had accepted the prognosis, and hence we could see that the grieving process had already begun with a lot of crying spells, where she would speak to her mother about how would she ever manage after she was gone. The patient's husband, as I said, was unable to accept the prognosis. He was oscillating between denial and anger and bargaining from time to time. When it comes to the total pain, again, since the patient was comatose, this is based on my understanding that I've plotted out the total pain. Speaking of physical pain, definitely there was metastasis, there was life-threatening disease, the patient being in end-of-life stage, being completely bedridden and comatose. Some of the socioeconomic factors which could have added to the total pain, as I said, poor lack of financial support, poor financial conditions, being estranged from family, so having no other social support as well from the community. Psychological pain, being stressed regarding daughter's education getting affected, and anxiety about the family's future, as in how her husband and daughter are going to manage after her. Both of these factors have been included because they were reported by the husband and daughter as being some of the unfinished business and some of the concerns that the patient had had when she was responding. The spiritual factors, as I said, there was no support from religion due to the interreligious marriage. So some of the discussion points that I would like to bring out here to the group are, one is, how can we generate support from the extended family? And even if we are able to generate support from them, would it be helpful or would it just add to the troubles of the caregivers? I would also like to discuss upon whether there could be any other sources of support for the family here. And any other discussion point that anybody else would like to bring up, you're most welcome.
Thank you, Ms. Mukta, for that wonderful case presentation. So
Thank you.
now the floor is open for all. So you can add your suggestion or any other queries of. Ms. Mukta, there is a question in the chat box. What is the family's relationship with their neighbors?
Yeah, I saw that. So when it comes to the neighbors, again, these are mostly, since they are staying in the company provided home, the others who are staying nearby are also working in the same company. So they are friends when it comes to their relationship, they are friendly. But again, the support is only extended to her father, to the I mean, not to the daughter. It doesn't extend to the daughter. Um, it's just that they do come sit with the father and talk about it. That's the extent of support that they get from the neighbors. But my real concern when I was dealing with this was that it seemed like there was too much responsibility on the daughter's shoulders, and we needed to do something about it. We also needed to I also tried speaking with the father regarding this, and he agreed that it was too much for a 20-year-old to handle, but he was too emotional, he was too drowned in his and overwhelmed with his emotions, and he was not really able to take any action about it.
There are more comments which are coming in the chat box. So visiting the patient in the hospital by the relatives reduce the anxiety for the daughter, and see the situation as it is and accept the situation by them. So Ms. Mukta, can I ask you
Yeah.
something? How about giving a supportive counseling for the daughter, and would it work, or what do you think
Yeah,
about
we
that?
had. Yes. We had been doing that. So we had sessions with the daughter to reduce her distress and all the anxiety that she was facing. So to make her emotionally a little bit more stable, we did do that. But still, these concerns were something which were very real concerns for her, especially when it came to the family, them blaming her, things like that. So even so, people who knew that she was in a comatose state and all would really like call her up and say that, see, if you would have listened to us and you would have taken her to TMH, this wouldn't have happened. So they were actually blaming her at that point, and that was really distressing her. But we did try. I mean, from our side, we did try to take sessions individually with her, and they did work up to an extent, definitely.
Hello, dear. I would just like to say something. Ideally,
Yes.
she's picked up a very. Is it okay?
Yes, no, definitely. Please.
The thing is that really she's very ideal and case which has all problems and issues. This is how we will see patient. Okay, we are not going to have easy catwalk with any patient, and always all things are there. See, especially first thing, the husband is the patient still in that same Goa Medical?
No, ma'am. Patient is in a
Okay,
palliative center. Yeah.
Is in the palliative center at present.
Yeah.
Is that right? Okay.
Yes.
See, ideal first thing, like that daughter being blamed will be blamed even if she does best or if she doesn't do best. Okay. Blaming is easy
Right.
job.
Right.
Okay. So being, even if you do the best, you will be blamed. Take it like that. So not giving importance to blaming is not the important thing now. Our main job in this is taking care. See, WHO has recently very clearly said patient and caregiver both have to be taken care of. Here, the daughter and the husband, because see, the patient will be taken care of for the patient's per se. Patient's care, patient's dignity, everything important. Next comes the caregiver. So here, both the daughter and husband have to be looked after. See, because the patient is just a very young 47-year-old, no one will accept. See, even though reality or inevitable is there, but accepting that inevitable is difficult. So that is where palliative care comes. Our main job and aim is we are going to give the best care and dignity so that we give what is good. We will correct the correctables. We will not hasten death, or we will not delay death. Nothing. We are not going to impact on anything, but give the best care to the patient and the caregivers. So here, counseling for the husband first. Denial phase will always be there. So you constantly keep talking to them. Do counseling sessions, first 5 minutes, 10 minutes. That same person will overcome the denial and come out of it. Only thing, perseverance and patience. 2-3 sessions of counseling the husband will need. Because see, first thing in this very strong, important thing is the husband and wife, they have been just by themselves because they have been disregarded by both their families. So for them, that element is always going to be there because they did not get any family support. For him, she is the only spouse, is the only person in this world or life what he has for him.
Yeah.
So that is why he is in that state. So regular or repeated counseling for the husband. In few second or third sitting, he will come out of denial. And then in that counseling itself, we have to say that his wife was one. Now next he has got his daughter. No point. He has to continue the relationship with the daughter. Okay. So first have counseling for the husband. And then after 2 or 3 sessions, combine the daughter also with the counseling session. Okay, so you try to rebuild. They already have seen that small nest of husband, wife, and child. That is what was their whole world. So that is important from counseling point of view. Next is support. You have to get some social care or other NGO support as things came up in the chat. Now, next thing is that looking after the education of that daughter. So there are NGOs or there are other people who are willing to help, but they don't know whom to help. So here you get the help of other NGOs or other systems which is in place, so that you just tap that, you link that to this person, so that the daughter gets. And then this issue of bringing the family together, no, is a big gamble game. Okay, it might backfire, it may not backfire. See, that one sister who is being good, she can be used as a tool to link the paternal side. Okay, right. You go meet into something and we'll all be in a big trouble. We don't want that. So utilize that one link that you have. That person will be the main link to whatever support or we want to give. You approach the family through that link person. Because we can't be dealing with all. For us, the patient and the carers are the important. So the whole link with, because see, end of the day, if that daughter gets, see, she's only a 20-year-old, so that has to be managed. So she gets, we have to see how much help she can get to continue and finish her studies and progress in her life. Okay, so these are the important things which have to be considered. The financial support, because at least if you give some counseling, let the husband spend for him. Why is he in denial? She was everything for him, and now she's not responsive. So that is what is causing him all the grief and agony and anger. See, today's topic, we saw all that. Okay, so that is why you brought up such a nice case, so that everything what was studied, you've had it in the case itself. So these are there. So that is why, see, exactly what I said. So for him, doing individual counseling, family counseling, all what we studied, we have put into practice in our session itself. Okay, all thanks to God that such a good case, even though last minute she said, very well prepared and well done, dear. So individual counseling, family counseling for him, so that the father-daughter relationship is what has to sustain and last long. Okay, even though he may lose his wife, he will have his daughter in her place. So these are things which has, see, psychology and individual second, and that's why, see, again, palliative care starts from the date of diagnosis and goes beyond bereavement. Okay, I think all of you know, whenever you study, there's a very big, clear representation of that. Palliative care is something which starts along with the diagnosis. Okay, at the time of diagnosis, palliative care is small. The curative care is more. For example, if you take a rectangle, the palliative care, that's a common pictorial representation you would have seen. Or else I will, finally, if we have time, I can share that also if you want. So it is one thing. So that is what will happen. If you don't mind, maybe I will share that. So it'll be a final thing. 1 minute, you wait. Because in one picture, you can have the whole thing. Can you all see the screen?
Yes, ma'am, we can see that.
See, this is what is palliative care. Okay, as I said, it's a pictorial representation. When it starts, disease modifying therapy makes bigger chunk. The yellow bit is the palliative care. The palliative care goes on the background, and it goes beyond. So that is how. So we have to go hand in hand. We have to do what is best for the patient. So initially, curative management, chemo, radio, or whatever, not only for cancer, palliative care is for everything, any long-term illness. So our support, the palliative care support, builds or increases, decreases according to the need. So here, for example, for this patient, now maximum support. So she is in a palliative care center. So she may be in that state. So the supportive care for the carer, the husband and the daughter has to go on. And so that is how. So involving NGO, having counseling sessions for the daughter separately, for the fathers, have sessions for the daughter and father separately, and then bring them together. And then from the family point of view, use the aunt who is in good terms, and then take it from there. This would be my approach, solving or dealing with all the issues raised up with that case. Okay.
Thank you, ma'am. Thank you so much. If there are no more questions, I think we can wind up. We are running out of time, I think.
Yes. That's what I saw just now.
If there are more queries regarding this, you can put it in the WhatsApp group. I'll be replying. I'll be forwarding to Radha ma'am. And thank you all.
So anything, and then you can share the presentation what I've sent if for them, whatever. And overall, big thank you to all of you, and hope it was a useful session to one and all.
Yes, it was a wonderful session. Thank you all for joining us today. Thank you, Mukta ma'am. She's also one of our faculty who regularly takes sessions for FCPM and FCPN. Thank you, ma'am. I knew it was in a short time we got into that case presentation, and it was very wonderful. Thank you all for joining us today. I have shared the feedback link with you. Please fill it up, and we'll see you on the next session. Bye-bye.
Thank you, one and all.